It's a pleasure to introduce Terry Inder, who will talk about cooling. I realize it's a little bit cool in the room also, so we asked to put the air conditioning a little bit higher again. But we did it especially so that you would be awake for this talk. Okay, Terry.
Hopefully the combination of caffeine plus a little cool environment will keep you awake. So I wanted to have a little bit of a feel for the audience in terms of what you are doing in your current practice. So, you know, hypothermia is something that is a very big advance for us. So how many of you in your current units would offer therapeutic hypothermia to term newborn infants that would come in with low APGAR scores and acidemia and other such things? How many of you offer therapeutic hypothermia at the moment? So the vast majority of you do. Okay, that's great. How many of you routinely can obtain a full EEG 24 hours a day, 70 days a week to monitor the EEG activity or monitor for seizures in the same baby that you've just put on therapeutic hypothermia? How many of you can acquire that? Okay, maybe a couple, 2, 3, 4. How many of you, if you can't get that, have limited channel, like a CFM, a single channel, or a dual channel? Okay, that's great. And then how many of you have an MRI scanner in your hospital facility? Have access to a scanner? Okay, now keep your hands up if you have access. How many of you use it routinely for this population of babies? Yeah, the vast majority. Okay, it's really helpful. Thank you very much. So we'll go into the talk and we'll touch on some of these things. So what I want to take you through is a little bit of a thought train about thinking about neuroprotection. And we're going to talk about therapeutic hypothermia, but I do want you to think about neuroprotection more broadly, not just as a single opportunity, but as a process by which you're going to think about what does this baby have, where am I at in the process, and what can I be doing to help this baby? So we're all familiar with this kind of setup. It's a tragedy for all of us when excited parents are met with a case of an infant who comes out down and requires our assistance, and we are very concerned for whether or not this baby will have life-altering cerebral injury. When we start to think about neuroprotection, this is the way I find it best to think about it. There are many stages where we could be intervening. We could be thinking about what kinds of things are happening early on in the pregnancy, what kinds of sensitization issues could be occurring. Was the infant growth restricted? Was the mother on different types of drugs or other things that could be affecting the vulnerability of the infant to brain injury? What is happening around the time of delivery? What happens immediately after delivery in the early hours to days? And then what happens late in delivery? And we're going to touch on each of these different timings to see what we know about neuroprotection in these different time periods. So let's start with potentially preventative treatments or understanding of these. And of course, in the preterm infant, there are some treatments that we know are very effective, antenatal steroids being the most effective, with a reduction of about 50% in the incidence of intraventricular hemorrhage, and therefore potentially flow-on effects for neurodevelopmental outcome, although that's not as clear. Magnesium sulfate, as many of you are aware, has now been examined for its reduction in motor deficits in preterm infants. But what about these term-born infants? Is there anything we could be offering, especially if we recognize there may be a risk for this baby? So this is going to be the one thing you'll probably remember well from this talk, and that is pomegranate juice. So pomegranate juice is high in polyphenols, it's well studied in adults, and it's been shown in a variety of adult diseases to have some benefit, and there doesn't seem to be any side effects. So why is it up here at the start of a talk on neuroprotection? Well, here's our little friend, the mouse, who's about to have a bad day. But his mother was fed pomegranate juice during the last third of pregnancy and then during the time of early breastfeeding. And then at 7 days of age, this mouse undergoes our common form of brain injury where we ligate the carotid and then place the mouse into hypoxia, 8% for 45 minutes. We also slightly heat up the chamber to get a consistent injury. And these mice usually undergo a pretty extensive injury on that side of the brain, and we compare that side of the brain against the other side of the brain. When we did this in the mice that had received the pomegranate juice, there was a dramatic reduction in the amount of brain injury by 2/3. And that mechanism of cell death that you had already heard about in meningitis, apoptosis, or cell suicide, was reduced by 84% in the hippocampus and 64% in the cortex. And we measured the levels of polyphenols in the mice, and you could confirm it had gone across the placenta. So this was the most dramatic neuroprotectant that we had administered in Dave Holtzman's lab, and he is our chair of neurology and studies multiple different types of neuroprotectants. And so he immediately wanted to try and take this forward into use in human infants. So we chose a model of growth restriction as a model where we could recognize perhaps an infant may be at risk for altered neurological outcome, and we decided to study the impact of pomegranate juice given to mothers during the last third of pregnancy. What we did to start with was we confirmed that we could get it into the placenta and into the fetus. These are the levels of 3 polyphenols in the 2 groups. The P is the pomegranate juice and the A is the control juice. And you can see at the time the mothers were first randomized, the average American diet, and these were mothers in a private clinic, the average American diet doesn't really have much of these in it. So none of the mothers had any polyphenols. And then we looked after they had been taking the juice for a period, actually in this first experiment, it was just 2 weeks that they took 1 8-ounce glass of pomegranate juice a day. And you can see the polyphenol levels, all 3 of them went up in the mother, and this is the fetus, the cord blood level. And there was very high correlation between the fetus and the mother, showing we could get it across the placenta into the baby. My colleague, Mike Nelson, then looked at the placentas in these same healthy term women just after 2 weeks of pomegranate juice ingestion. And what he did was look at heat shock protein as a measure of oxidant stress. This is a control placenta, and all those bright dark stains are heat shock protein. And here is the pomegranate mother's placenta. You can see notably there's much less, and whether you look at it via the staining or the expression, you can see markedly less heat shock protein 90. And he went on to then study in vitro the action of pomegranate juice on the placenta, showing marked reduction in oxidant stress in the placenta. We were more interested in going on with the babies, and so we basically, these were the 2 randomized groups, and we collected a lot of data, including an MRI, and we're now following these babies up. In our phase 1, there was 40 babies. They were pretty evenly distributed, but some withdrew. Of those that completed, there was a couple who were unable to take any juice, or that the babies were too unstable, or the MRI data was not able to be used by us. So we were left with 30 who had MRIs. 2 of them were extremely preterm, so that left us 28 that are in this phase of the analysis. In these babies, these babies when they were delivered at term, you can see the difference here in the 3 levels. This actual elevation was actually really just due to 2 mothers who actually had a fetish on almonds, and almonds can also elevate your polyphenol levels. So, but you can see across the levels that the cord blood levels were higher in the pomegranate babies. We went on and looked at the brain imaging for this diffusion imaging, and we measured the brain size just by simple metrics. And what we found was when we looked at the microstructure of the brain, that the babies whose mothers had received pomegranate juice had what we call decreased diffusion, so they had a more mature looking pattern in this anterior limb. And they also had better organized microstructure. Remember, this anisotropy, better organized microstructure in the main motor tract and in the optic visual tract. We also found that they had better organized frontal white matter, both in terms of both of these measures of diffusion and within the left motor tract. Here's just some representative standard T2 weighted coronal images. Here's a pomegranate baby and an apple juice baby. There was only one baby that had abnormalities on our injury scoring, and you can see here the ventricular dilatation and the loss of signal there. But what we did notice was that the apple juice babies seemed to have a little more space around the brain. Some of the ventricles looked a little bigger, and the brain looked a little narrower. So we measured those using Catherine Garral's fetal measurements, and indeed we saw that the biparietal diameter was bigger in the pomegranate baby, and that these spaces around the brain were smaller in the pomegranate babies. And these were all adjusted, all of the measurements you've seen, for gender, gestational age at birth in the scan. So we feel that there may be some hope to perhaps provide, even though it seems as silly as pomegranate juice, something useful early in babies where we may be able to identify perinatal risk factors, and particularly those that may have increased inflammation or oxidant stress. But in our baby that we're talking about today, we didn't have that opportunity. So here we go, our baby's born, they come out with low APGAR scores requiring resuscitation. What can I do now? And the thing we will focus on is hypothermia and anticonvulsant therapy. So when you think about this particular mechanism now, following a hypoxic ischemic, and it is predominantly an ischemic-driven cerebral injury, what phases and things am I thinking about? Well, in the first few hours, depending on the nature of the insult, there may be a lot of overwhelming immediate cell death, this necrosis. You know, the AK-47 comes out and is sprayed around and all the cells die. And this may be why in certain types of severe brain injury, we have little capacity to still influence the outcome. However, in the mild and moderate types of brain injury, the vast majority of death is not this form. It's this cell suicide that you've been hearing about in the immature brain. And that takes place over hours, days, and weeks. So you have this long window of opportunity to be able to interrupt that process. Two of the key things that are influencing it, though, relate to this oxidant stress and excitotoxic injury, which starts very early, within hours, and then the secondary phase of inflammation. So how does hypothermia work? Why is it that even offering something to a baby who already had a lack of blood flow and oxygen even works? Well, this was elucidated by Peter Gluckman and Alistair Gunn very early on when they took fetal lambs and followed the pathway to injury. And what they showed was that when you have a primary injury, so you clamp the cord on the fetal lamb or you cut off blood flow, you will get this primary injury. You will have some primary cell death, but it's a very small number of cells that actually immediately die. Then as the flow is returned, the baby perks up, the animal perks up, everything looks pretty good actually. But underneath, these cells are suffering from a cascading sort of reaction that started back at the time of the initial insult, but goes through over hours to days when the cell functions start to break down, the mitochondria stop working well, and by about 6 to 18 hours, you are well fledged into secondary energy failure. Once you hit this point, you're at the point of no return. This point clinically is often recognized with onset of seizures or worsening of seizures. So that's a nice hallmark for you. By the time, in fact, in the fetal lamb, if the fetal lamb was having seizures, hypothermia had no benefit. If you intervene between these 2 points, then you can downregulate every one of these mechanisms by hypothermia. And that leads to a sort of a cessation of the cascade to here, and therefore prevention of further injury that's ongoing in the brain. So it's a remarkable opportunity, but it requires vigilance. Because if you don't get in till here, i.e. the magic 6-hour window, then you will miss all of the opportunity to gain this benefit. So what do we know about the hypothermia trials? So this is the old Cochrane review, which at that stage had 8 unmasked randomized controlled trials with 638 near-term infants. I can tell you we've just finished the second systematic review. There are now 2,018 near-term infants who have been randomized into trials, and the findings are almost completely unchanged. So the forest plots you've got used to now. So this is selective head cooling on the top, this is whole body cooling on the bottom, and this is combined. And what you can see is that in the vast majority of these studies that there is benefit, with approximately a 25% reduction in death or disability, with the number needed to treat, I think it might be on the next slide, there you go, number needed to treat 7. The number needed to treat now varies between 6 and 8 in the new Cochrane review, and the relative risk is still identical. The most important thing when we started these studies was we were very worried we were going to be pulling babies back from the brink and they would survive, but then we would increase the number of disabled citizens within the community. So it was very reassuring to see that even in survivors, you reduced the risk of neurodevelopmental disability, and reduced it quite considerably, as you can see here, with a relative risk of 0.68 for significant impairment. The adverse effects of hypothermia, we'll talk about a little bit more as we go on. The only adverse effects that continue to be present in the ongoing review are those of thrombocytopenia and the increased need for inotrope support. There is about a 10% increase of having a platelet count less than 100 and about a 10% increased risk for inotropic support. Things that I would like to be able to talk about before we stop are what do you do with a baby who has significant coagulopathy? Should you cool them? Should you continue to cool them? And then a new era has dawned where people are noticing a lot of persistent pulmonary hypertension in babies receiving therapeutic hypothermia. What do I do about that? Is it because of the hypothermia? Should I warm the baby up? So hypothermia, though, is really important to think about as a very careful medical therapy. Sometimes I see people talking about it as though, well, you just like stop warming the baby up, just cool, just throw a little ice pack on them, which was the study we did, which is what we did do. We threw a little ice pack on them. But, you know, it's really the way you manage and treat these children will make a big difference. It's not all the same. So the way you cool them, the method you use will affect things. Brain-injured babies will drop their body temperature, and they'll drop it rapidly, as I'll show you in a moment. Resuscitation under overheads can increase body and brain temperature to inadvertent hyperthermia, which we, of course, want to avoid. Everything you do when you heat up the brain accelerates all of those processes that we want to cool down and take away. So you do want to turn off the radiant warmer. Sometimes I call it the gorilla, and we all know when we're putting lines in how much it feels like that when we're under it. So, you know, the first studies that were actually done by Alistair Gunn's mother, Tanya Gunn, when I was a medical student, she didn't actually have any cooling devices. She built a shield to protect the baby's head from the overhead radiant warmer because she didn't want the radiant warmer directly on the baby's brain or skull. So we do try to avoid and switch off if we know a baby is in a situation where they have emerged that would be eligible for hypothermia. No attention to temperature, as I've said, can lead to profound hypothermia, which we want to avoid. And this is from Mariana Thorison's beautiful review, which I would recommend to you all to have a look at. Here is a baby, and we've had many of these types of babies, as I'm sure all of you that are in a lot of cooling centres. This was where the baby was first recorded. They turned off the overhead warmer and waited for the transport team to get there. When the transport team arrived, the baby's temperature was below 28 degrees. And then the transport team slowly warmed the baby up to the temperature level that we want the baby to be at before the baby then was re-warmed as part of the standard protocol. And you can see the characteristics of this baby, a very high-risk baby for a profound cerebral injury, but we do not want to be down in this range. The overhead radiant warmer is shown here, and its effect on a piglet model within Mariana's lab. These are when the radiant warmer is off, radiant warmers turned on. Deep brain, rectal, superficial brain, scalp. Look, all going up. Radiant warmer off, radiant warmer on, radiant warmer off. So you get the idea. It really does have effects right down into the deep brain. Whatever device you use can also affect the stability of your cooling, and these are 3 different methods. So this is selective head cooling with the cooling cap device with mild body hypothermia, the cooling mattress, or here is the critical cooling body wrap. And this is a more servo-controlled, more tightly servo-controlled technique than the other 2 techniques currently offer. And this is the technique actually that we have moved to because of this closeness of stability of monitoring the degree of hypothermia. So the take-home message really from this piece is monitor your temperature. How many of you are using rectal probes? Okay, how many of you have most or at least a third of your babies referred from outside hospitals for this type of treatment? Only a few. So what I would say is it's really important when you talk to the outside hospitals that they have rectal probes as well, because you can't monitor the temperature in any other way than these rectal thermometers, and they're really pretty simple devices. In the States they cost about $200, and you can provide them as a thank you for all the referrals you're getting, if you like. But you know, they will mean that the baby will be safe while your transport team goes out to pick the baby up if you want to commence cooling in the field. The method, as I've said, can influence the stability, and please avoid hypothermia. What else do you need to think about? We've already heard here a beautiful talk about drug metabolism being altered, and particularly for drugs metabolized in the liver. You will see sinus bradycardia, and in fact there's a trial going on at the moment through the NICHD network where they are dropping the body temperature to 32.5 in a randomized trial. And apparently the sinus bradycardia noted in some of those babies has been as low as even 60 to 70. We don't believe that that is necessarily harmful, and we certainly don't worry as our babies drop down towards 80. And in fact, the babies I worry about the most are those that don't show bradycardia. If you don't see any bradycardia at all, you can be fairly sure you've got significant brainstem injury because the infant's unable to mount an appropriate response. And those babies usually need to be evaluated rapidly for whether we should be continuing intensive care treatment. Sedation and stress. How many of you are using standard sedation with hypothermia? Okay. So we didn't start out using sedation with hypothermia, and then there was some interesting animal data published by Mariana Thoresen again, showing that if the animals suffered cold stress, you negated all of the benefit of the hypothermia. So we feel strongly that you do, particularly if you're treating mild or moderate babies, that you do need to abolish that cold stress. And some of you may see them. They say babies can't shiver, but I've seen plenty of them actually stressed and shivering. So we use morphine at the reduced rates that were quoted the other day. We do give a decent loading dose of 0.1 because I do think they need to get up fast if you're going to have cooled them. And then we use a very low infusion dose for the 6 hours in reducing down. And I'm very happy to send anybody our hypothermia protocol as well that we have in our unit. Interestingly, there was only one of the trials, and it will not be noted in the Cochrane review. There's only one of the trials that actually systematically used sedation, and that was the European trial, and that showed the largest effect size. The largest benefit with therapeutic hypothermia was seen in that trial. And I think in our own personal experience, we believe that it really does make a big difference to these babies. Feeding. Nutrition is going to be important in these babies, and often you'll see people withhold feeding and not start TPN, or withhold all nutritional intake sometimes for several days. We don't think that is ideal. If you're going to withhold feeding because you think the gut may have taken a significant ischemic insult, or you feel anxious about the effect of hypothermia on feeding, then please consider starting adequate parenteral nutrition at the same time. And you may consider, if you feel comfortable, giving some non-nutritive, very small amounts of breast milk. Maintain adequate blood pressure is important. You should be monitoring that. Ideally, one day we'll be monitoring cerebral perfusion as well and know exactly what systemic blood pressures mean. But at the moment, make sure you avoid hypotension. And then at the time you start to rewarm, monitor your baby very closely. So every trial has used the same recipe. That recipe was based on actually 3 lambs. So 3 lambs were taken to that temperature for this period of time, and we found the best benefit we thought we could find, and we thought we needed to move rapidly into clinical trial. But the length of time for 72 hours may or may not be the right length of time for your baby. As we'll talk about, this apoptosis may be going on for quite a considerable period of time. So watch your baby carefully as you rewarm. We rewarm extremely slowly over 12 hours. And we watch very carefully, monitoring any baby that's had seizures with continuous EEG monitoring, but also watching with an encephalopathy score for any alteration in the baby's behaviour. If either of these things occur, and I've seen babies go from discontinuous traces into near status, or certainly into profound burst suppression on rewarming, if that happens, we take their body temperature back down, and then we warm them up over 0.5 degree every 12 hours, very slowly. So you have to be very alert to this time period. It's stated by those who've had a lot of experience cooling that about 20% of the babies will deteriorate during the rewarming phase. And here's an example of that, where you see the temperature is up now at 35, the baby is starting to have a lot of seizures, gets treated, and then drops the temperature again, and now you can see the baby's back. Not quite back to the healthier pattern before the rewarming, but at least stopped seizing. So let's talk a little bit more about seizures in this setting. Before I do that, I will comment, as I said, on persistent pulmonary hypertension. How many of you have noted persistent pulmonary hypertension in infants with therapeutic hypothermia? Does anyone want to say what they do about that? Do you rewarm? Do you rewarm those babies? Nitric oxide. You stopped once? Yeah. You stopped?
Well, it was on nitric oxide, and we went to decide for ECMO or...
ECMO. Did it improve? Did? So there's very little data out there. The data that is out there suggests that somewhere around 10 to 15% of infants on therapeutic hypothermia will have evidence of persistent pulmonary hypertension, and probably somewhere around 10% may go on to nitric oxide therapy. What people are suggesting is that if you think that's evolving, to go early. Don't wait to sort of see whether this is going to get worse or not. Start the nitric oxide early. And then try to stabilize the baby with other measures without rewarming. There is only one case series where they have followed the rewarming, and all of the babies actually deteriorated with rewarming. So there is no direct evidence that the hypothermia is causing the persistent pulmonary hypotension. It may be if the baby is stressed and not adequately sedated, it may be contributing. But I would warn caution that you may be worried about going to ECMO, but actually now there is two case series of babies on ECMO who have had systemic hypothermia, therapeutic hypothermia administered on ECMO. So there is actually no data that you cannot stay on ECMO actually and go right through the process on therapeutic hypothermia. So you are risking everything you are gaining on the brain for the case of something that may not be irreversible. It just may have to be carefully managed. So please think about it. There's a knee jerk. We've got to warm the baby up. It's the hypothermia, and I'm not sure it's true. And so I would try to caution that. The second thing I hear often is people will say the baby is in DIC. We need to warm the baby up because I'm worried about the coagulopathy. Don't do that either. Manage the coagulopathy. As you know, for these asphyxiated babies, it's very common for them to have a degree of disordered coagulation. There is no evidence on any of these trials now with over 2,000 babies of an increased rate of hemorrhage. So you don't have to be treating this baby differently. Some people will have a slightly different platelet threshold, you know, because of an ischemic cerebral injury. They may have a platelet threshold of 80 or 50 rather than 20. There's no data to sort of guide you, but I feel it's fine if you want to give some extra platelets a little more earlier than that. But don't please warm these babies up because there is some moderate or even severe coagulopathy. There is no evidence, and no baby was rewarmed in any of these trials because of those indications. No baby was rewarmed in these trials because of pulmonary hypertension either. So I think we have to be careful that we are bringing in a different approach than we can. How many of you will start treatment in a baby who turns up at your unit after 6 hours of age? 7.5 hours of age, here's this nice 39-week baby. He's really cute. What are you going to do? Are you going to treat? Who would treat? I would treat. Okay, so we don't know the answer. We will, maybe, one day. There is a late trial that has now been started. What I will tell you is that there is evidence, and we've just published some, that therapeutic hypothermia reduces seizures. It's a pretty effective anti-epileptic, actually. So even between 6 and 12 hours, you may still be in a window where you may be able to offer benefit even if it's anti-epileptic. 25% of the children in the Vermont-Oxford network that we'll talk about in a minute were treated outside of the 6-hour window. So people are doing it, even if it's not you. In the same way, 10% of the babies in that network were less than 35 weeks gestation. That I feel a little more anxious about. I think we have to wait for data about safety in the preterm or the sort of late preterm, 32 to 35 weeker. So moving into seizures, I know you've already had a talk on this, so I'll go fairly fast through this piece. Should we monitor all infants at risk for seizures? Well, the clear message has got to get through to you that you don't know when someone is seizing. I don't know when someone is seizing, and the more I know, the less I know. So somewhere between 1/3 to 90% of seizures are subclinical. Even worse, 2/3 of the abnormal movements that you see don't have an EEG correlate. So you can see something you think's a seizure and it's not. Somebody can be in status and you won't know. And it's not because you're not good at what you do. You just can't tell. Even worse, you see something that you think is a seizure, you give them anticonvulsant therapy, and then you're really done, really toasted, because they'll stop jerking, but they don't stop seizing. So the EEG continues to show ongoing seizure activity. It's just now you've sort of antagonized the brainstem such that they can't show any convulsive activity. So this beautiful little study came out of Ireland, 51 infants with encephalopathy and all risk for HIE. They gave prophylactic phenobarbital to all of their infants at risk. So their rates of actual infants that had seizures were quite low. Out of that 51, only 12 of them actually had seizures. And then they had 526 of the seizures that were documented. When you looked at those seizures, only 48 of them, or 9%, were clinically recognized by anybody, the nurse, the physician, anybody. And even when they went back on video and really looked, they got to 20%. So it's pretty tough. There were 3 infants who were aggressively treated for up to 31 clinical events, but they never actually had a seizure. Some of them got 3 drugs. 2 infants didn't have any therapy, and one had 38 seizures and the other had 56 seizures. So when you take this all together, 5 infants received completely incorrect treatment. 3 of them didn't got all this aggressive treatment for things that weren't going on. 2 of them didn't get any treatment when they needed it. I don't know where else in medicine it would be okay that 50% of our patients were getting the wrong treatment. So the really critical question that you have to ask yourselves is, could monitoring actually make a difference and improve outcomes? And Mona has been here, and there is some retrospective data from intensive AEG monitoring and therapy for subclinical seizures that shows a rational reduction in post-neonatal epilepsy in this high-risk population. And then there's this one very provocative study that came out a long time ago now that's not been repeated, where one dose of phenobarbital was given between 1 and 6 hours of age and showed dramatic improvement in developmental outcomes in the follow-up of these children. There's also been a subsequent paper now that's just come out from the Alabama group suggesting that early phenobarbital prophylactically like this with therapeutic hypothermia had an improved outcome compared to just hypothermia alone. And there certainly is animal experimental data to support that too. So can we detect these seizures easily? Well, it's a problem, and many of you will have seen a monitor like this. This is a BRM monitor. This is the 10-second EEG output. This is the amplitude integrated output. And these little bars going off here are the seizure detection algorithm, highlighting where, as you can see clearly here, there may be seizure activity seen to help identify at the bedside when seizures may be occurring. So we went about trying to do this in a randomized study, monitoring these babies for 3 days. We also put in conventional, and now we have it for the full 72 hours. The babies were randomized to either a blinded group where no one could see whether the baby was having seizures, or the monitored group where you could tell if the baby was having a seizure. The algorithm would go off and some clinical decisions about initiating or changing treatment were made. In the other treatment, it was just standard of care, whatever was decided by the clinician, and our standard regime is phenobarbital, fosphenytoin, and midazolam infusion. So how good are we on limited channel with a seizure alert? In this first phase, and we've just finished the second phase with 80 more babies that we're analysing at the moment, in this first phase, about 2/3 of our infants had seizures, and this is more typical in the particularly pre-hypothermia era. There were a lot of seizures, over 1,000. When we looked at the seizures that were on both conventional and on the AEG for the periods we had monitored, there were 385 events picked up on conventional, and over 80% you could see on the limited channel. So that's actually, I thought, was pretty good. Here's this figure again. We looked on the monitor, on the video monitor, on conventional EEG. 94% of the seizures were subclinical. You could not tell this baby was seizing at all. The algorithm went off only just over half of the time, but I'll show you here. The important thing that you can see is that the seizures that were missed by that alarm were the very short seizures, less than 30 seconds. Most of the longer seizures were actually picked up, or over 3/4 of those seizures that were more than 30 seconds long. What did we see about the difference between these two groups? So here's the blinded and the monitored. You can see that actually the amount of seizure activity when you were monitoring was able to be halved, and the amount of seizure burden per patient was able to be halved. And the preliminary outcomes, we're just finishing up, but the trend is looking to be similar, was that there was improvement in motor outcomes, language outcomes in this group. So monitoring the seizure burden was associated with a trend towards reduced seizure burden, and this may correlate with improved outcomes, which we will finish, and we will finish with another 80 babies before we finally report this, and that's being undertaken in collaboration with my neurology and neonatology colleagues. So there are two things you could be doing right now. You could be offering therapeutic hypothermia, you could be monitoring the brain carefully for seizures and targeting treatment to the right babies, not exposing babies that don't need it. But what else can we have in the future? Well, there are experiments going on at the moment in the United Kingdom with inhaled xenon for 12 hours. Xenon is an anesthetic gas which can reduce the amount of excitatory amino acid activity. Allopurinol is actually really interesting, and there is some positive data. It's just never got to the next phase of trial. Erythropoietin at the moment is being considered for trial for these babies within the United States, and I think a 10-center trial will probably start within the next year, but it will probably be 5 years before you get that data. And there has been consideration of trial in the United Kingdom with melatonin. We've already heard about NF-kappa beta, for an anti-apoptotic effect, but there's a lot of concern in the neuroscience field about these drugs because apoptosis is a natural thing that actually occurs within the brain. We have more neurons than we need as an infant, and we do have to undergo selective cell suicide to form the right degree of connections, and it's a very carefully balanced process that we don't want to upset. And the same with JNK inhibitors. So finally, I'll just touch on repair and regeneration. Oh, no, I'm going to flick through some of this for time. I do want to show you one piece here. So how many of you would still undertake CT scanning in any of your babies? Do any of you use CT scanning routinely? Nope. Gosh, you are remarkably more informed than the vast majority of North American centres that went into this study. So in this study, this was actually, and it's just under consideration for publication at the moment, 4,000 infants with neonatal encephalopathy in the Vermont-Oxford network. About 1/3 of those infants received a CT scan. Just over half of those infants had an MRI scan, and some infants, a small number, had the privilege of both. So when we compared CT scanning to MRI imaging, you can see MRI imaging captured many, many more of these infants in terms of the patterns of injury that are particularly important. Deep nuclear grey matter injury was picked up 3 times more commonly, and vascular lesions like stroke twice as commonly. Of course, we are very concerned about radiation exposure in the immature brain with CT scanning, and we find no reason to indicate a test that is suboptimal in terms of its diagnostic capacity and that has that risk. So this has also been compared by Steve Miller, and you can see here on day 3 of life, diffusion restrictions in the basal ganglia that are not as clearly visible on CT, and he reported this as well. So why is MRI scanning not necessarily used by all of you here or available? And it's difficult because the baby's got to lie still. Do you use sedation or anesthesia? How do you monitor the baby? And then how do you kind of get in with your radiologist so that babies matter? So we do all of our imaging without sedation, and we feed our babies about half an hour before they go to the scanner. We have some little ear muffs and their monitoring equipment, and then we wrap and pack them into this little beanie bag. And we suck the air out of the beanie bag, and it forms like a little kind of like a mold around them. And most of our parents ask if they can take the beanie bag home at the end of the scanner because the babies are all so comfortable and quiet during the scan. But this really helps prevent head motion, and we have over 90-95% success rate, and we've imaged thousands of babies clinically. In fact, we use this for all babies under 4 months of age. What do you see on MR imaging in this condition? So this is pre-hypothermia data, and I just want to highlight this for what I think is an important point. So here are diffusion images, T1, T2, and FLAIR. And you can see the diffusion imaging here becoming prominent for an infarct around 3 days. And then down here on conventional imaging around a week, you can see it. And the diffusion imaging, if anything, is now bright, so it's sort of reversed. So this was reported appropriately. You can see here, particularly for measuring diffusion, you had this prominent fall by day 2, and then by about day 7, the diffusion had completely normalized. So if you do your scan out here with a baby who's not getting hypothermia, diffusion is not very useful between day 5 and day 7 because it'll be negative, and yet your conventional imaging may not be yet visible. You're going to have to wait sort of till after 7 days. So we were interested to see if hypothermia showed us something different, and I don't know where it went, but it does. So I don't know where the other plot went, but what we see in hypothermia is that actually this tail now comes right out like this. So you will still see restriction and diffusion up to 12 to 14 days after the injury. So when we first started seeing this, we had images we were doing around day 5 or day 7, and the radiologists were reporting day 7 changes with restriction and diffusion must mean the baby had an insult 3 or 4 days ago, which didn't make us feel good because we were looking after the baby. But that's not the case. This tail goes out, and indeed we think we are slowing a process that has, oh, here it is here. Here's the hypothermia data. So you can see a much, much longer tail. So if you do your imaging around here, the process is still ongoing. So you have to wait to image these babies with therapeutic hypothermia as long as anybody can stand, which in our unit we try and do day 10 imaging, 7 days after we've rewarmed. We realize there's still a little bit of a process going on, but we can still usually see the bulk of the findings that are relevant for prognosis. So why is imaging powerful to help you? Well, there are 2 key patterns that people talk about for these babies. The deep nuclear grey matter pattern. These babies will usually have had low acid base, encephalopathy. These ones you kind of recognize. These babies with this sort of watershed between the anterior and the middle or the posterior and the middle, you may not recognize these babies so well. These babies might come out not looking so bad. They might need a little bit of resuscitation. They are encephalopathic, but it will be one of those ones where they look a bit stunned, but you think they're kind of okay. So you kind of bundle them up with the mother to the postnatal ward, and then someone calls you at 12 hours of age when they see the first seizure. Or they get sent back down for a septic workup because they're not feeding. And this will be the type of pattern that that baby will fit. Why does this matter? Well, it matters because this pattern here is very prognostically powerful for profound impairment, particularly profound cerebral palsy, feeding disturbances, and actually a high risk for epilepsy as well. In contrast, this pattern, there is still a risk for later subtle cognitive deficits. They're more clumsy. They will perform below, particularly in visuospatial and language tasks. But it's a much less impacting condition than that of the basal ganglia injury. Mary Rutherford observed one sign, the absence of these bright myelination signals within the posterior limb. So you can see here it's absent, here it's bright, and these sort of train tracks, if you like, which are the motor tracks. Here you've got abnormal signal around the train track, but the train track is empty. It doesn't have this bright track. That sign alone could predict the presence of an abnormal outcome with a sensitivity of 0.9 and a specificity of 1. So if you had an abnormal plic, you were abnormal. If you had a normal plic, high likelihood that you would be normal. One single sign on your MRI that can be very powerful as long as the MRI is done at least after day 5 without hypothermia, and I would say day 7 with hypothermia. Finally, the HOPE stem cells. Well, these babies have native stem cells lying around the ventricle, and if you injure the brain, as has happened in this mouse model of Donna Ferrero's, you will see a chain of them feeding out to the area of injury to try and help the brain regenerate naturally. And we see a rind of this kind of activity in our babies with injury, and actually in our preterm population at term, this is correlated with better outcomes. We hope we can support that recovery, if you like, by growth factors that might be able to enhance the natural regeneration of the brain during this time period. And if you look at what erythropoietin does during that time period, it can increase the number of cells, the amount of neurogenesis you will see even 6 weeks after injury has occurred. So this is where we believe erythropoietin may have a role in the next phase of the regeneration and repair of the brain following injury. There has been a randomized controlled trial here reported in China with treatment every other day for 2 weeks, and it was reported to improve the neurological signs early on and reduce or halve the amount of death and disability. So as I say, a phase 3 trial at the moment in the United States is planned. Remember, after your baby goes home from the hospital, this is what the brain wants to do. These are the density of synapses within the cortex. Remember, between 2 and 18 months, there is this massive expansion. This is why those little toddlers are running around, like pulling the videos into the video machine, running in and out of the cupboard, doing everything, because their little synapses up here are like going crazy. Then they're going to prune. But you've got all this opportunity to assist a brain that's been injured to repair and adapt and function well. And one of the critical things we think may be important may be nutrition in allowing this process to occur, because undernutrition during the first year of life is associated with all of these bad things. Conversely, one study was done which randomized infants with brain injury to either 120 or 100% protein-calorie intake. The study was terminated when 16 subjects had completed the protocol due to a greater than 1 standard deviation difference in head circumference at 12 months of age, and those receiving the higher energy and protein diet. They also looked at axonal diameters by electrophysiology and showed that they were larger in the corticospinal tract in the infants who'd received the higher energy and protein intake. So I think this challenges us, one, to replicate this trial, but also to think about a much more protracted period of neuroprotection. In the same way, there's always a lot of debate, does early intervention really work? Well, there's a lot of heterogeneity between the trials, and a lot of this is that we need to have more targeted understanding of what intervention we're going to offer for which baby, depending on which pattern of brain injury. But there is some data which would support us to consider particularly things like the new constraint-induced movement treatments that for focal infarcts are producing dramatic results. This is what the brain wants to do from the time it's term till it's 6 years. There's areas of dramatic expansion, particularly around the parietal, temporal and frontal areas. And one brain can do this in the setting of intensive environmental enhancement, or it cannot expand as occurred in this particular infant. So we can be responsible for a lot of adaptation and recovery. So in summary, I really hope that you can take away that neuroprotection requires a couple of critical steps. Recognition of the infant in need of neuroprotection is really important, and there was a recent abstract where 240 infants were screened for potential hypothermia. Only 40 infants were treated. Of the 90 infants that were said by the clinical team not to need hypothermia because they were deemed to be too mild, because their neurological exam was normal or mild, 20% of those infants either died or were severely disabled. What does that mean? I think it means we have an opportunity to improve our clinical acumen about how to recognize infants with encephalopathy. We currently we're good at recognizing respiratory distress, we're good at saying somebody's in difficulty, but we're not so good at recognizing a baby who's not behaving in a typical or appropriate way. And we really need to have in place systems, and again I can share with you a standard neonatal neuro exam we use based on the NICHD exam. You need to have a system in place where people are recognizing what is abnormal in a baby's behavior. Then you need to consider where you are in the phase of the injury and what your target is. But certainly treat hypothermia like a drug. Use it carefully, monitor it carefully, optimize all of the other things that will make it as effective as possible. Recognize and target treatment, particularly for subclinical seizures. Watch carefully for additional therapies, xenon and EPO. And then all infants with cerebral injury will benefit from optimal repair and regeneration. Nutrition, parenting, and therapy. So thank you very much for your attention.
Hypothermia,